Good afternoon, everyone. I'm Dr. Kim Newell-Green, and I'll be the moderator for today's virtual Grand Rounds. Today's Grand Rounds is called Long COVID in the Brain, Neurological and Psychological Impacts of Long COVID. I just want to remind us that the California Department of Public Health is our strong partner in providing relevant public health education for physicians in California, and we're grateful for that. Next slide, please. Next slide, please. Here are our speakers' disclosures. Next slide, please. This is our agenda for today. I'll note that Dr. Helen Lavretsky is unable to be here right at this moment. We're hoping that she'll finish what she's doing and be able to join us. But for the moment, we have Dr. Elise Singer with us. Next slide, please. So just as a reminder that this series is accredited for CME credit. When we get to the next slide, we'll see those details. You'll be sent a survey after the completion of the webinar where you can attest to attendance. And upon completion of the survey, we'll send out your certificates. So getting into the meat of what we're talking about today. 3 years after the COVID-19 pandemic started, we know much more about long COVID than we ever did, and yet there are still so many mysteries. Today, we're hoping to have 2 long COVID experts from the University of California, Los Angeles, Dr. Helen Lavretsky and Dr. Elise Singer. And we see Dr. Singer here who's having a misspelling of her name due to technological problems. But these 2 doctors, or at least Dr. Singer, will present the latest data and clinical care recommendations about the neurological and psychological manifestations of long COVID. So right now I'm going to introduce Dr. Elise Singer. Dr. Singer is a health sciences professor of neurology at UCLA who specializes in infections that affect the nervous system. She's had an emphasis on HIV and now SARS-CoV-2. She's a principal investigator of the National Neurological AIDS Bank, which is a biobank that specializes in neurological infection. She has extensive experience in clinical research, clinical trials, and teaches at all levels. And she also works quite a deal with community advocacy groups. We're so pleased to have her today. So Dr. Singer, take it away.
Hi, how are you? I will do my best to substitute for Helen. I'm not a psychiatrist, so I may go a little light on some of those areas. As mentioned, I have no conflicts except for an NIH grant, and my background has primarily been in HIV and other infections of the nervous system. I was the person who volunteered for being the long COVID neurologist, and it's been quite an experience. Next slide. And so this is my conflicts. Next slide. So the first thing I wanted to say is that the system to care for persons living with the long-term sequelae of SARS-CoV-2 does not exist. And I took this from another physician who said this, but I thought it was really helpful. There is no secret sauce. There is nothing that we are doing here at UCLA, or very little, that couldn't be done in most other large medical centers. This is really the biggest single problem. The system is not set up to deal with a mass casualty or mass disabling event. Next. Here is a picture. I don't see excuse me, I don't see the side panel with the writing on it. But this is a picture of, you can see Robin Williams and Robert De Niro. And what I had written there, which seems to have disappeared, is that it is very common for people to have sequelae that are neurologic and psychiatric from infections, particularly respiratory infections. This is not anything new in the history of the world. It is common. People had post-encephalitic Parkinsonism after the influenza epidemic. We don't know if it was the same virus or a traveler virus that was going along with it. There's an enormous amount of material that's been published recently about the fact that people who develop pneumonias, particularly older people, are at very high risk for getting dementias, as well as people with herpes simplex infections, and that vaccines are probably one of our best preventative measures for dementia, and probably do a lot more to reduce the risk of Alzheimer's than many of the drugs that are being investigated now. Next. One of these papers is a national study done by the VA that showed a significantly elevated level of neurologic and psychiatric disorders in the 12-month period after COVID. They looked at people beginning 30 days after the first evidence of COVID, so that they were not getting people right away. They did not want to look at people who might have been demented coming into the study but weren't diagnosed. They looked at this and they found that the risks and burdens of neuropsychiatric problems were elevated even if the person was not hospitalized. And I think that's very important. I've seen a lot of people who had relatively what I would call mild cases of COVID who then went out and got fairly severe and demonstrable and clearly new neurologic disease. The VA study probably underestimated some of these risks because they overrepresented white men in the study. And as many of you know, a lot more long COVID sufferers are female. The incident neurologic disorders were including, but were not limited to, stroke, problems with cognition and memory, migraines, seizures, movement and musculoskeletal disorders, Guillain-Barré syndromes, and encephalopathy. And the incident mental health disorders included major depression, stress, adjustment disorders, anxiety disorders, and psychotic disorders. And the reference is below. Next. So there are a whole huge number of long COVID symptoms that I've seen, some very exotic and interesting and some very meat and potatoes, but I'm going to focus on just a few because we can't do everything here today. And those are cognitive dysfunction, also known as brain fog. I hate the term brain fog because it trivializes what's going on and it also is a misnomer. Most of these patients have executive dysfunction related to the frontal part of the brain. Autonomic symptoms, because they can so easily be diagnosed or misdiagnosed as anxiety, including POTS and orthostatic hypotension, and small fiber neuropathy, because it's a very hard thing to diagnose, as we will discuss. The symptoms are very vague, like tingling and pain and dizziness and discoloration. And if you're not a neurologist, you probably haven't heard much about this term, and yet it's really common. And I think once you understand it, it can really help you manage your patients. The other things which we're not going to discuss that much today are headaches, sleep disturbances, the increase in stroke and cerebrovascular diseases, the cranial neuropathies such as anosmia and ageusia, tinnitus and vertigo, and the cerebrovascular diseases. I will make one comment that the increased risk for cerebrovascular diseases is now known to linger at least 6 months after the initial infection is over. And I have had a couple people who developed strokes after their COVID infection that were clearly caused by COVID. They did not have risk factors, they were young, and this is something that you do need to be mindful of. Next. Next, okay. So in being a person who knew nothing about COVID when I first started, but was overwhelmed with patients, I tried to make a little bit of organization for myself so that I could approach these patients in a systematic way. And I'm going to give you my approach to cognitive complaints in long COVID patients. You may find something else works better for you, but this is a good, I think, place to start. And the first thing I do is consider the alternatives. Can we go back to the last slide, please? Go one more ahead now. Can you? Yeah, that's it. The first thing is this an exacerbation of a pre-existing disorder? So it's very important to ask the person, well, how are you doing and did you have any problems before you got COVID? Because there is an overrepresentation of people with attention deficit hyperactivity disorder and with prodromal cognitive and neurologic problems that get worse after COVID. For example, I've had a gentleman, very nice gentleman, a physician, who had a family history of Alzheimer's, was slowing up a little bit, got COVID, got delirious, even though he wasn't febrile and did not have hypoxia, and then was completely unable to return to work. Very elaborate workup at UCLA shows he had Alzheimer's. He probably would have developed it anyway, but it was really, the pace of the disease was really uncovered or accelerated, I believe, by the COVID. And I will explain why later in the discussion. People who were in the ICU or had critical illness during acute COVID can have permanent or at least long-lasting cognitive and motor dysfunction due to hypoxia, ischemia, clotting disorders, delirium, and sepsis. These don't resolve the minute that the person is discharged from the hospital, and they often seem worse when the patient tries to resume their normal activities and becomes frustrated that they can't do things that they used to do before. Surprisingly, I have seen a couple of strokes in young people, both during the COVID period and after the COVID period, who were not febrile, were not critically ill. They had no other risk factors but COVID, and this is something that you do need to look out for. There is also a tremendous amount of PTSD, and I am not a psychiatrist, but I've seen many cases of this now that can clearly overlap with the more typical neurologic problems. PTSD occurred because a lot of these patients were in the ICU, they were isolated, some of them were intubated, they were delirious, they were on medications that altered their consciousness. They may have witnessed somebody else having a cardiac arrest or coding. In one case, I had a patient who was given steroids for his COVID and then developed a horrible gastric bleed and almost bled to death in the ICU. So there's a great deal of this. And then there's some PTSD, I think, as well, from people just listening to the TV and hearing all these horrific things that made everything very scary. Anxiety and depression is something that's often exacerbated when the patient has the ability to go back to work and finds that they can't do their usual work, their exercise, their hobbies, their relationships. Can't tell you how many people I have who go, well, before this happened, I was running 20 miles a day and I was an athlete and this was how I managed my stress, and now I can't do it. And I just want to go back to exactly the way I was before COVID. And of course, this is not rational, but doesn't make a difference. People are mourning the loss of their abilities. Next. So first thing I'm going to address is cognitive dysfunction, AKA brain fog. And again, I hate that term. And when patients say I have brain fog, I say, well, what does that mean to you? So here are some real patient complaints from my clinic. This is from a postdoc in protein biology. I used an equation in my experiments over 300 times, and I could not recall how to perform the calculations. This was somebody who couldn't finish up their postdoc because they just couldn't think through their work, even though they had been doing it perfectly up to the time of COVID. And even on just bedside testing, she did very poorly in a lot of tasks that involved planning, so on. Next person was, and I was in the middle of a pediatric code and couldn't recall the name of a drug I use all the time. This was one of the attendings at a major teaching institution in Los Angeles, who's a pediatric critical care specialist who used to resuscitate neonates. She is no longer employed at that job. I have trouble finding words when I need them. They come back later. I quit work because I don't think I can bring down a school shooter. That's my favorite. I went to the refrigerator and couldn't remember why I opened it. I left the stove, gas, or water on. The door opened, didn't pay my bill. The dog ran out in the yard and hasn't been seen again because I forgot to close the door. These are all really common. Next. Usual presentation of cognitive dysfunction in long COVID. I won't say there's only one presentation, but the more common presentation is that of a dysexecutive syndrome. And I was hoping that, we would have somebody with more background in neuropsych who could explain this in more detail, but I'll do my best. A dysexecutive syndrome primarily affects the frontal part of the brain. It does not usually present with focal neurologic findings on exam like Babinski or weakness. And if you see that, you need to think about other etiologies such as stroke. Again, brain fog is not a medical diagnosis and trivializes the problem. It also doesn't give us any direction toward rehabilitating the patient. Dysexecutive syndrome is something that affects executive function. Think of executive function like your air traffic controller of your brain. Even though he's not flying the plane or she's not flying the plane, you can't land the plane without them. And the executive functions include things like working memory, cognitive flexibility, and very importantly, inhibition control. So you need the inhibition control to filter out all these extraneous stimuli in your environment while you're thinking. And if you don't have that, you'll lose track of what you're doing, pay attention to something else, and then go back and go, hey, what was I doing? So executive dysfunction can present with problems in things like planning, reasoning, and problem solving. And the way the patients are often distracted, described by their employers or their friends, are that they are distractible, spaced out, or even unmotivated. And that's not the case unmotivated. They just can't control their attention. Next. So here's somebody who I asked them to draw a clock and put in all the elements, and you can see they left out the actual clock face. They put in some nice little numbers. They couldn't figure out how to plan enough to get all of the numbers in the right thing, and this was a college-educated person. So you can see that there are some planning problems here. My first approach is I tell the patient, you got to turn off your phone. I know that's not science, but they're so distractible, it just makes it impossible to do any kind of exam. Next thing I tell them is it's very important for me to talk to a collateral informant, if there's one, like their spouse, their roommate, because often you can't get neuropsych testing, but you can get information from somebody independent in the house who's watched them do things that are not normal for them. You need to ask about traumatic brain injury, attention deficit and hyperactivity disorder, problems with sleep, problems with substance use, and their psychiatric history. All of these things are overrepresented in patients who are complaining of this problem. And in fact, COVID makes all of them worse. Bedside tests like the mini-mental may not pick up a problem, particularly in a highly educated person. And neuropsych testing is really, really helpful because it allows you to compare the patient's performance to people of their educational and socially matched strata, and gives you norms that are valid for them. And a big part of the problem is that we can't get the patient's neuropsych tested, partly because of lack of resources, partly because insurance companies do not want to pay. So we then use the bedside tests, but they remember that a negative bedside test does not mean that the patient is not having a problem. basically everybody needs your usual dementia workup labs: thyroid, SED-RAID, CBC, HIV test, RPR, B12, urine tox, because sometimes you find that people are taking drugs that they didn't tell you about, or have other problems. In general, after doing tons of negative autoimmune workups, while I'm convinced that many of the features of long COVID are probably due to autoimmune diseases, I'm also convinced that most of these folks will not show up with an autoimmune antibody of any of our usual panels that we get from routine labs. And so they're technically often very not helpful. I think it's extremely important to screen for sleep apnea and other sleep disorders in this crowd. And there's a couple of reasons for this. One is that sleep disturbance has a huge major impact on cognition and mood, as well as memory. And that many people who had mild or minimal sleep apnea prior to COVID get much worse after COVID. I'm not sure why, but it's an observation that I am very aware of. And it may have to do with lung damage or damage to the medulla. I am not sure why, but it is something that's highly treatable and can often really improve the patient's mood and cognition. Next slide. When imaging the brain, I think it's very important to try to improve the yield, because it's expensive, it takes time. And I see a lot of people who have gone for MRIs where I think a better yield could have been gotten for the money and the time and the effort. So if you find a patient who really has no focal findings on your neuro exam, is not complaining of anything like seizures or loss of consciousness, and has a normal screening mental status, most cases non-contrast brain MRI will be sufficient and should be basically used to calm their fears. If the patient asks you about microclots, you need to tell them that most of the scanners that we use in clinical neurology and clinical medicine around here are 1T and 3T scanners, and they do not have the field strength to find a microclot. It might find ischemic disease of other sorts, but it's not going to be the microclots that people are talking about in COVID. This requires an MRI with a field strength around 11. The research that was done on this was done in cadaver brains, because an 11T MRI is not authorized for use in living humans. And so if they are going to somebody who says that they're going to find microclots in their brain with a special MRI, and they're not at NIH or someplace like that, you know that there's something going wrong there. If the person is complaining of ataxia or incoordination, a good thing to request is extra posterior fossa views. That way, by the time they get to the neurologist, which they will need to do, we'll have a scan that will actually look at the relevant area as well. And that isn't something that people normally do unless you tell the radiologist. If the patient is complaining of vertigo or tinnitus, add in thin cuts through the internal auditory canals and do both with and without contrast on your MRI. You're looking for problems with the inner ear that may show up. Again, higher resolution MRI are better for these types of things. If they're cognitively impaired, especially if they're elderly, ask for a volumetric brain MRI if your radiologist can provide it. This is basically a way of looking at the amount of atrophy in the different lobes of the brain. Not only does it provide a baseline, but it can help you diagnose conditions like Alzheimer's disease. If you think the patient has venous thrombosis because they've got excruciating headaches, add MR venography. If you suspect demyelinating diseases or seizures, always do the with and without contrast. And again, most of the commercial MRIs do not have the field strength to detect much of what is going on with the patients in many cases. Next slide. The next thing I'm going to talk about is small fiber neuropathy, because it's not that neuropathy that you learned about in medical school. It is something that neurologists do see a lot of, and we have had a better appreciation of recently. And it is a little hard to diagnose and sometimes a little hard to treat. So small fibers are A, delta, and C fibers. They carry sensations like temperature, pain, and they also are autonomic. They often surround small blood vessels, and they can increase and decrease the diameter of the small blood vessels. When they don't work, you tend to get a pooling of blood in areas like your feet. And the feet often turn purple, and here's a patient of mine with purple feet and edema. So you can see that I was highly suspicious of small fiber neuropathy in this person before I even began much of my exam. The findings are kind of subtle. They're not as easily detected as you would find in somebody with, for example, bad diabetic neuropathy. They have mild or often mild abnormalities in light touch, pinprick, and vibration, temperature. They may have decreased ankle jerks, but they don't have motor loss. This is that autonomic nerves do not cause that problem. And very importantly, their EMG and nerve conduction velocity will be normal. And doing an EMG and nerve conduction on a person with this type of picture, even though you can see that they look grossly abnormal, is not going to detect anything unless they have another kind of neuropathy. EMG only really works on the larger, more myelinated fibers in the legs and arms. What you need to do to detect this is to look for the loss of small fibers in the skin. And on the left, you can see these little black traces, which are immunostained for small fibers. And on the right, you can see, you don't see very much of that. And basically, the test for this is a skin biopsy. Next slide. Now, to make it more complicated, unfortunately, this is not an etiologic diagnosis. It's characteristic in many conditions, including long COVID, other infections, immunologic disease, metabolic disorders. You can see it in diabetes too, but it's not the same thing as your usual diabetic neuropathy. And you can see it in pre-diabetes. The symptoms are very vague. They're tingling, burning, pricking, electric shock-like pain, along with the discoloration of feet and hands. It usually begins in the feet, but it can involve other areas, including the hands and sometimes even the torso or face in very bad cases. And it may be associated with dry eyes or mouth pupillary abnormalities, bladder problems, or abnormal sweating. Again, these nerves innervate or perform autonomic functions. Again, EMG and nerve conduction velocities will only detect the neuropathies of large myelinated fibers. And the small fiber neuropathy can be diagnosed one of two ways: clinical diagnosis, or if for some reason you have to have a definitive diagnosis, by skin biopsy. Skin biopsy is specific, but it is not sensitive. You often have to get multiple areas of skin to find one that is a good fit for the testing. It's expensive, and it has to be sent to a special lab, which charges a lot of money. So again, most of these diagnoses are going to be made on clinical signs, which is one of the reasons that I use pictures to illustrate it. I think that sometimes your eyes are better than the testing. The treatment is symptomatic for the most part, basically pain control, unless you can identify something that causes the problem that's known to respond to a specific treatment, like a vitamin deficiency, an antibiotic, or a specific autoimmune disorder that responds to a specific disease. One of the problems with small fiber neuropathies is that they can exacerbate the patient's already present from COVID autonomic problems by allowing blood to pool in dependent areas. So a lot of these patients will say, when I stand up, I get dizzy, I feel faint, things like that. And, or I get dizzy, I get a headache when I stand up. These are things you don't normally associate with neuropathy, but they can certainly exacerbate these problems. Next. So that kind of leads us into the autonomic symptoms that you can see in long COVID. Autonomic dysfunction, again, is not an unknown thing in viral infections. And most typical presentation, although certainly not the only one, is sympathetic overactivity like tachycardia, palpitations. You see this in Guillain-Barré syndrome. It can be a life-threatening complication of Guillain-Barré. And the hard part is that you can be hard to distinguish this from the anxiety that the patients have. But if it's autonomic, it can be dangerous. I've had patients with orthostatic hypotension that have passed out when standing up, fallen down, and had concussions. That's pretty serious. Arrhythmias, gastroparesis, you can diagnose that with a gastric emptying study. Color changes in the extremities, dry eyes, mouth, and ED, although that's not a particularly good criteria for diagnosing it. And as you can see here, you can look at this young lady's hands and you can see some of the abnormalities that she has in coloration. Next slide. So how do you approach this? None of us are experts in this. There are people who do autonomic neurology, and Mayo Clinic is very good, Stanford is very good. Most neurologists get a few minutes or this, or maybe a couple of hours in their training, because it's not something that we often need to deal with in a very detailed way. That's going to change. So there are a couple of ways you can approach this in clinic. There's an autonomic questionnaire the patient can do online and score online, and you can just ask them about fainting, feeling pre-syncopal after standing up, fast heartbeat when they're resting and doing nothing, and early satiety. An active stand test, which basically looks at blood pressure and pulse before and after postural changes, can be administered and scored by a non-physician in your office. Alternatively, and we prefer this, but we realize that we at UCLA are in a somewhat privileged position, you can send the patient to a lab for autonomic testing, such as cardiac monitor, tilt table test, sweat test, pupillary reflexes, and so on. The nice part of that is you get a much more refined idea about exactly what neurological problems the patient has and the best ways to treat them. You may find things that you didn't even know about that the patient is, going to need to be treated for. The treatment is mostly tailored to the symptoms, but typically what we do here is if people are having orthostatic hypotension or POTS, we use hydration. We have them increase their salt intake. We have some patients on compression hose. Patients tend not to like that, but it does help. They may need midodrine, which is an alpha adrenergic blocker, to raise their blood pressure, but this drug should not be given at night to avoid supine hypertension. We use beta blockers sometimes to slow patients' tachycardia. Physical therapy is important because it can teach your patient how to get up slowly and reduce the number of falls and concussions. Next. Next. So here is a little pictograph of autonomic testing. This is the tilt table test. You strap the patient to the table and they have a cardiac monitor on, and the table is gradually taken from the horizontal to the vertical position with the patient attached. They don't have to get up or use their muscles in any way, and measure the heart rate, blood pressure, sweating, etc. There's also quantitative pseudomotor axon reflex test or sweat test. I don't perform this myself. I've never performed it. Thermoregulatory testing, and the gastric emptying test. I've only seen 1 or 2 cases of gastroparesis in long COVID. In one case, it was a kid who needed a feeding tube because she couldn't eat any other way. She just couldn't empty her stomach. And urodynamic tests, which can be performed by your local urologist. Next. I'm going to conclude here because I think I've overwhelmed everybody, and hopefully Dr. Lavretsky has joined us and can talk more about the psychiatric issues in long COVID. Thank you.
Thanks so much, Dr. Singer. We'll have you stick around. I am told that we have Dr. Lavretsky with us. So, Helen, if you're here. Oh, good. Can you see a little camera button? Maybe you can click that and see if we can see your face. And the team will get your slides up, and then welcome very much. So while we're working on that, I'm just going to introduce Dr. Helen Lavretsky. Dr. Lavretsky, and Dr. Singer, if you'd like, you can turn your camera off now. We'll turn it back on when we have time for questions.
Let me first have to find where my camera is, but yeah.
Dr. Lavretsky is a professor in the Department of Psychiatry at UCLA and a geriatric integrative psychiatrist with research interests in geriatric mood and cognitive disorders and integrative medicine. She's a distinguished investigator with recognition from many specialty societies, and she now directs the post-COVID clinic at UCLA, among her many other roles. So we're so pleased to have you here with us, and you can carry on with your presentation. Thanks.
Yes, very good. Thank you so much. And Elise was very comprehensive. So let me just cover highlights of what I think is relevant for understanding mental health burden. Next. Okay, next. Next. Okay, so we'll cover these topics, stress and mental health, neuropsychiatric symptoms and management principles. Next. So this is the curve of response to mass disasters, and certainly applies to the pandemic. Has to do with multiple stresses like multiple losses, fear of death, social isolation, increases in alcohol and substance abuse, increase in suicides. And this curve signifies levels of distress. First acute wave 1, now we're in phase 4, dealing with the fallout and chronic consequences of the pandemic infections and not providing adequate care for chronic diseases of all sorts. And the dotted line represents those with pre-existing mental health problems, conditions. So they typically have a primed response to stress and tend to have higher levels of distress with the pandemic stressors. Next. So this is the reality. Still, at the height of the pandemic, about 40% of adults reported symptoms of anxiety or depression compared to 11% pre-COVID. It dipped a little bit in June of 2022, but still is higher. And the majority of people live in the federal designated mental health shortage areas. So that's a lot of people in underserved areas. And there are very few of us compared to the number of people who need mental health services. Next. That places pressure on primary care providers to know more about screening and management. As far as neuropsychiatric symptoms, the most common one Elise covered: fatigue, brain fog, cognitive impairment, chronic malaise, anxiety, depression, PTSD, increased suicidality, psychosis, and delirium. Next. And sources of psychiatric symptoms, as I said, trauma, of being hospitalized or just dealing with the social isolation, pandemic issues, delirium, inflammatory changes, cytokine storm, vasculitis, microvascular disease in the brain that is documented by neuroimaging, multi-organ inflammation, and dysautonomia. Next. So this is an interesting study that stems from the review of 70 million electronic health records that identify rates of psychiatric conditions, neuropsychiatric symptoms being about 33.6%, and 12.8, almost 13% new onset. And for patients who were admitted to ICU, it's double that, much higher. And this is much higher than in other viral respiratory infections like influenza or any other respiratory tract infections. And that's to say that this infection, COVID-19 infection, is very neurotrophic. Next. Which is documented by early studies of PET studies documenting clusters of hypermetabolism in the rectal orbital gyres at the base of the brain, including olfactory gyres, and it is one of the pathways of getting to the brain is through the olfactory passages. Right temporal lobe, including amygdala and hippocampus, extending to right thalamus, which signifies the centers of memory and emotion regulation, and bilateral pons, medulla, brainstem, cerebellum, that would explain multiple somatic complaints, postural hypertension, and many other changes in basic physiological functions. Next. MRI finds heterogeneous lesions, acute and subacute infarctions, leukoencephalopathy, microhemorrhages, leptomeningeal changes, and flare signal abnormalities, with about 30% being hemorrhagic lesions and 24% white matter hyperintensities. Next. We published this letter in 2021 where we included some of our patients, the two 30-year-old and 60-year-old on the right are COVID patients compared to health control 44-year-old. And the 60-year-old patient has many more white matter changes, signifying microvascular and inflammatory changes in the important areas important for cognitive functioning. She is complaining of severe long haul COVID symptoms, including depression, insomnia, and mild cognitive impairment, and incidental finding of left hippocampal cyst. Next. So common principles of management of neuropsychiatric complications consider infection versus stress of the pandemic and related changes in the lifestyle. Recognize that patients with pre-existing psychiatric illness are more likely to become infected with SARS-CoV-2 and experience neuropsychiatric consequences of COVID-19 and have worse medical outcomes. Symptoms should be monitored longitudinally at regular intervals, hopefully using rating scales, very brief self-rating questionnaires for depression, anxiety, post-traumatic stress, substance abuse, suicidality, and cognitive concerns. We have we use PROMIS 29 questionnaire and some additional PHQ-9 questions or brief PTSD screen to identify the symptoms before patients come in. Apply evidence-based behavioral and pharmacological therapies that address symptoms like they do in other medically ill populations, and be aware of potential drug-drug interactions, especially in light of COVID-19 pro-inflammatory, pro-thrombotic, and arrhythmogenic effects. Given multiple organ systems, we practice a multidisciplinary clinic, sharing patients with cardiology, nephrology, infectious disease, pulmonology, neurology, rehabilitation medicine. We have meetings every 2 weeks, discuss cases, especially the difficult ones. And I train other primary care physicians, extensivists, to take care of mild to moderate cases with neuropsychiatric symptoms simply because there are too many. Telehealth represents an opportunity to expand access to mental health. It's been a blessing for patients with COVID who have severe symptoms and are not able to come to the office necessarily. Next. This is the VA recommendations for whole person health application to management of long COVID, where integrative medicine principles and lifestyle medicine are recommended was assessing all aspects of well-being, like spiritual, psychological, lifestyle, sleep, diet, exercise, and toxic exposure, and relationship, personal development, life and work. Next. I practice integrative medicine, and that's why I got into long COVID. I'm a researcher mostly, mind-body medicine, yoga, hypnotherapy, spirituality, tai chi, qigong, expressive therapies, breathing techniques. So in all of my patients, I introduce one or more modalities of integrative medicine to help themselves to self-regulate, rebalance their body, to decrease sympathetic response, stress response, and activate parasympathetic system with deep breathing techniques or Tai Chi and Qigong. Many of them are debilitated and they can start with just brief practices, breathing, and then transition to Qigong or slow movement exercise, art and dance. I use sound healing and music therapy. Next. So psychotropic drugs, as a psychiatrist, I do use, and many of the primary care physicians use antidepressants, all sorts, for constellation of depression, anxiety, chronic pain, insomnia, to select a single antidepressant that helps all of this. Bupropion and vortioxetine can help ADHD symptoms of concentration problems, energy problems. Anticonvulsives like lamotrigine and gabapentin can target anxiety, insomnia, and pain. Antipsychotics can be used to augment poor response to antidepressants or for dissociative symptoms or psychotic symptoms. Stimulants are very much asked for in patients with brain fog. I use them sparingly for performances, let's say for taking an exam or giving a talk, not constantly, because they exhaust chronic fatigue patients. Cognitive enhancers like memantine I do use due to neuroplastic properties of the drug. It is approved for treatment of Alzheimer's disease, but I've done studies in older adults with geriatric depression, treatment-resistant, and cognitive complaints. So it's a very similar constellation of symptoms where memantine was very helpful. Sedatives we don't use too much of. I use supplements rather than sedatives. Psychotherapy of all sorts can be very, very helpful, especially trauma-informed, like acceptance therapy, cognitive behavioral, dialectical behavioral therapy, and trauma techniques like emotion freedom technique, EFT, and EMDR. Group therapy was very helpful in the beginning and continues to be helpful as a part of management. Acceptance and cognitive behavioral therapy are very helpful as elements. And then disability is another pandemic that we spend a lot of time on. Next. Next. This is the same slide, yep. Lifestyle, stress reduction, as I said, exercise, mindfulness, yoga, Tai Chi, supplements for brain health like vitamin B, complex D, fish oil, ginkgo, anti-inflammatories, adaptogen like ashwagandha, rhodiola, rosea, ginseng, supplements for sleep, melatonin, and deep sleep is the name of the herbal supplement. For anxiety, valerian root and sound healing, ginseng and adaptogens for fatigue. Diets, we do discuss antihistamine, anti-inflammatory, Mediterranean, and the use of probiotics to supplement because gut health really suffers. Patients have a lot of GI symptoms. Breathing exercises, as I said, 3-3-3-3 breaths or 4-4-6-2 breaths with a longer exhale on 6 seconds. And then yoga and qigong targeting dysautonomia and stress-related symptoms. Next. Pulmonary rehab with mind-body interventions is very helpful for those with lung damage, pain management with CBT, acupuncture, and ketamine, sleep management, as Elise said, with treatment of sleep, because that's one of the most responsive symptoms to management, and it can change other domains like cognition and mood. Cognitive interventions, as I said, memantine memory and cognitive training, cognitive and vocational rehabilitation. We do send patients for brain stimulation for severe non-responsive symptoms like repetitive transcranial magnetic stimulation, RTMS or TDCS. Next. Okay, thank you.
Whew, that was a whirlwind, Dr. Levetsky. Thank you. I feel much smarter and more educated, and I hope all of us do. If we can, Dr. Singer, if you can pop back on your camera, we do have a bunch of questions. The audience has been super interested in what you've been presenting. I just want to start with one thing you didn't mention on your slides, Helen, which is yoga for the fear of death. I'd love to just hear what that meant. It was intriguing.
Yes, so fear of death and dying was so prominent during COVID, and even after, like as pandemic was winding down, some patients who had severe experiences with post-COVID and hospitalizations were terrified of stepping out of their homes, leaving their homes, for the fear still exists, for the fear of getting another COVID infection. And I use specifically techniques to reduce that stress, and with graded exposure, slow exposure. Like, for example, if they are afraid to leave the house completely, they don't step out of the door, I would do the breathing exercise, relaxation techniques, and make them step out 1 step, then 2 steps, then 3 steps. Same approach I had for graded exercises was for dysautonomia, just 1 step every day, adding very, very graded, very gradual increase.
Mm-hmm. Great, that's helpful. So one question that everybody had is sort of, what do you each see as the typical course of neuropsych symptoms in long COVID? Do you see sort of a gradual improvement in many patients? Is it remitting and relapsing? Just for some it worsens over time? Maybe you can each take that.
Okay. Yes. So on average, in younger, more robust patients, we expect improvement, not to the previous level of functioning, but the significant noticeable improvement that they're happy with within 6 to 12 months.
Mm-hmm. Mm-hmm.
And it could be more complicated with multiple comorbidities like diabetes and other cardiovascular, cerebrovascular illnesses. We do things to improve increase time to respond, improve time to response, like vitamin supplementation, cognitive rehabilitation. I send them for memory training, mindfulness training, which also through my research has cognitive benefit. All of these techniques, any new learning with, like, let's say they've never done yoga or tai chi and they have to learn it, would improve their cognition.
Great. And Dr. Singer, what's your sort of sense in your patient population on?
Well, I think it's probably biased by the nature of the persons that I see versus some of the other doctors. In general, if it's a healthy young person, I would say 6 to 12 months. Cognitive rehab, which we do here through speech language pathology, really, really helps, especially with the executive dysfunction. With the older people, there's another issue here that I think has been hugely ignored, and that is the relationship of these inflammatory diseases to accelerating the course of underlying genetic predisposition to dementia. There are some enzymes that are activated by cytokines that can phosphorylate tau, which, as you know, is an abnormal protein associated with Alzheimer's and many other neurodegenerative diseases. And certainly, we are probably missing a lot of the very, very subtle vascular disease because we don't have the tools to screen people. So I would say that in most young people, it's going to be fine. They will get through this. For some of the older people, I think we're going to be seeing a huge amount of people presenting earlier than they would have normally with neurodegenerative disease. I hope I'm wrong, but I think that there is a real concern here.
Interesting. A lot of people are asking, of course, the $6 million question. And I know, Dr. Singer, you and I had talked about your wait list just being egregiously long. And so the real question is, how much of this can a primary care doc do, the screening and the assessment and the initial treatments? And when do they refer? And And once it's time to refer, who do people refer to? Dr. Singer, you talked about the fact that there really isn't a big system for this yet. And do you know, either of you have any plans to set up, for example, centers of excellence for long COVID?
There's no money.
Yeah.
That's the end of the story. There's no money. And even the multidisciplinary thing, which I think is essential to what we're doing, I can't tell you how much I've learned from Helen and the other people here, and I hope they've learned a little bit from me too. And this isn't my first rodeo. I've come out of the HIV docs, and before that I worked in pain clinics. So I think for any new area, multidisciplinary work is extremely important, because a lot of it, what you're doing is just gathering information that's valid. There are so many problems in medicine right now that I don't see that without changing some of the administrative, and I don't know what proper word to say, maybe Helen will figure it out, issues that we are going to be able to set up what we need to help people. Because there are a lot of barriers to working in interdisciplinary settings. That's a big one. There's just, I mean, yes, I can teach a primary doctor to do a lot of the stuff that I do, but do they have the time? Get scheduled for 7 minutes, come on. The only reason I can do this is I'm in an academic setting and I can ask for more time. And a lot of the time that I spend is actually spent bonding with the patient. Because if they don't trust you and they don't believe you and they don't think that you're for them, anything you say is going to go out the window. They've got their phone, they've got their support group. They are, the amount of misinformation about this disease is shocking. Helen and I have a patient who was, I think I mentioned, drinking dirt.
So, another part of it is vaccinations. What vaccinations do, we don't understand. They probably do add to some heterogeneity in the symptoms that we see. I think what primary care physicians can do with the patients is to address a whole person well-being, referring them to lifestyle changes. And as much as possible. So what I do, I create a program for each patient based on their preferences. And I have a menu of things that they can do. I send everybody to the beach, to acupuncture, if they're receptive to that, to dance. I find out how do they reduce stress. So a lot is placed on the patient's well-being, management of their own well-being. And I think by doing it, you are also involving patients' participation in their own well-being. This is a chronic disease de novo, okay? For 18, 20-year-olds, 40-year-olds, it's all in the middle of their big plans for their future, and it's not going to happen. So, and the mortality and lifespan will be shortened. So you have to train them to participate in their own well-being and reduce their expectations for improvement. And it's one day at a time, one foot in front of the other, work for your improvement. Every day, do something for your body and mind.
So much wisdom, and I wish I had more time with you. There are a lot more questions, but that's all the time we have today for questions and commentary. And I really want to thank you both, Helen and Elise, for being here with today, for presenting today's content, and thanks to everyone listening in. Those of you listening in, reminding you that you'll receive a survey about 5 p.m. today. You can attest to attendance, and then we'll send out your CMA certificates. Please note we will not be having a regularly scheduled session during the month of June, so our next session will be Tuesday, July 11th, and we look forward to seeing many of you there. Have a great rest of your day, and thanks again.